Welcome, Katie O'Donnell, to the Surgery and Therapy Summit. I'm going to be Surgery and Therapy Summit. I'm going to be interviewing you today just so that our audience and attendees can learn a little bit more about you.
Great, yeah, absolutely.
So tell us, you're living in Southampton at the moment in the UK?
Yeah, so I'm Irish originally. I work in Southampton as an advanced occupational therapist in hand therapy and rheumatology.
Okay, and I believe that's where you began. So it's almost full circle for you.
Yeah, serendipitously, my last placement as a student a very long time ago, 13 years ago, I think it was in the hand therapy department in Southampton University Hospital, where I now work. And it made me really fall in love with hand therapy. And I was quite besotted, actually. I went off and spent my first, when I qualified, I did my first BAT level 1 kind of off my own back, because I was just so interested in that world of hand therapy. And then kind of went off and actually ended up specializing in neuro rehab for a long period of time. So saw a lot of kind of brain injury, spinal cord injury, kind of other neurological conditions like Guillain-Barré syndrome. But my interest throughout all those years was always in the upper limb rehab perspective of things. That's kind of where I felt my passion was. And I really enjoyed that rehab aspect of things, either splinting those patients that were being treated from a Botox perspective or trying to enable them to have more functional use of their hands, using electrical stimulation for recovery. And then 5 years ago, we looked at leaving London, where I was working. And we came down to Southampton, and I actually ended up taking the job of my old supervisor in my final placement thing, which worked out quite well, which is brilliant. Lovely to be back.
Oh, that's so nice. And you've also gone more on an academic route. So in the UK, you can become an accredited hand therapist through the British Association of Hand Therapy. As you mentioned, you did your level 1. But you've chosen to do an MSc, which is very admirable when you have a full family life and you are very busy at work.
Yeah, so I've done kind of my BAT level 1, and I did 2 of the BAT level 2s, which served me really well from a work purpose in terms of the skills that I came away with. And then when I was looking at where I wanted my career to go, actually, because I see quite a lot of more unusual cases and presentations, I felt that some of the BAT modules necessarily wouldn't suit my needs clinically or academically. And I looked at the MSc routes. So I'm midway through that. I've just completed my PG cert in hand therapy. And so September, I'll restart again, and I'll be looking to finish my diploma, and then it'll be my dissertation. So yes, it's quite busy because I work full time and balancing, like you said, family life and some additional private work, and trying to have a social life at sometimes it is a challenge, but it's really rewarding. I think the academic side of things really helps quieten down the kind of imposter syndrome. It gives you a really solid foundation of what you're doing, and I feel like my understanding of the evidence has been so much better since engaging in that process.
Absolutely. Well, it makes you an analytical thinker, which is crucial.
Yeah, and it just gives you that headspace to kind of sit back at even at the kind of everyday problems, just really look at what the evidence is saying, like you said, and analyze it rather than just reading the paper, trying to appreciate everything and where the whole body of evidence is and what that really means for therapy, which is actually, it's really enlightening, really helpful. And really good from a clinical perspective as well, because it leads to quite a lot of change into the clinical perspective, because you don't necessarily, if you're purely in a clinical zone, you don't always have the time to kind of step out and look at the whole picture. So it's each time I kind of finish a module or complete my assignments, I can kind of see the bits that we need to change and progress within my department, which is great.
And especially as a lead, because they can see that academically you're prioritizing that journey. And then, of course, when you come to mentoring and working with your students, you just instilling that kind of way about working, in that is to look at the evidence and to implement it and to, read the articles. So well done. I think that's great. And there may be a PhD on the horizon.
Yeah, I think we'll get the master's under the way, get the family on board. But I think that definitely that academic journey has been much more interesting and exciting than I even thought it would be. And actually it's really tangible, useful stuff that changes the practice that I work in, changes my patients' experience of things. So I think that's definitely where I'm looking at going forward. Yeah.
And so you're going to be teaching us some splinting at the summit, which is wonderful.
Yeah.
along with Bob Phillips. So tell us a little bit about why you're so passionate about splinting.
I think, and I'm going to be really biased because I'm an occupational therapist, but I think kind of OTs, in theory, if we have our biomechanics and we have our anatomy down, we are incredible players when we're looking at rehabilitation, because we should be able to really fine tune what patients' functional goals are and how we get there for them, be it through a splint temporarily, be it through kind of rehab activities or kind of looking at that recovery process. The stuff that I've been really interested in is incorporating my neuro rehab background and my neurological background with the patients presenting to me in hand therapy. So I see lots of patients that have upper limb problems that potentially aren't going to get any better, be it from a spinal cord injury or a myopathy, Guillain-Barré syndrome, Charcot-Marie tooth. I see a wide range of those patients. And they have very specific goals that are really meaningful for them. And with the best will in the world, our exercise programs are not going to get them to recover their range of movement. So we need to think about their functional goals, their meaningful activities, and what we can do to achieve that for them. And over the years, I've found there's been a couple of splints or more that have made real meaningful difference to my patients. So I've had a patient with really significant arthritis that's grossly reduced the range of movement, and the stuff that he really missed was being able to cut his own food, and he was a 50-something-year-old gentleman, and being able to make him a splint that was quite simple, that held a knife on a ring apparatus that he could slide on, meant that for the first time in a couple of years he was able to cut his own food, and that was much more meaningful than gaining a 10 degrees arc of movement for him. He could do the things that were important. Similarly, there's been things like spinal cord injury patients up on the ward that I've been asked to see, to think about making resting splints, and actually when we look at them, they're a C5-6, they've got a little bit of wrist extension or a nice tenodesis activity going on, and all he really wanted to do, because he was a couple of hours from home, because we're a major trauma centre, he wanted to be able to hold his mobile phone and be able to FaceTime his family, and he could work it so far with the Siri and everything else, so he could do all the voice activation, but he couldn't physically hold the phone. So I made a really simple mobile phone bracelet, so it just meant that he could again slip it onto his hand and quite simply talk to his family, and it compensated for that lack of finger activity that he had with things. So there's been kind of lots of those bits that have been really meaningful, that actually have made a big difference and are much more appreciated than making potentially a resting splint for those patients.
Absolutely. And, you know, that takes a lot of practice. You have to have worked in with that varied diagnosis. And specifically in neuro wards, I think, because that is when you really are going to get the challenges. Because in my practice, it's all trauma, and you know, they healthy individuals with no neurological deficits, you know, central neurological deficits, and so I know that they're going to get better. And our goals are quite clear. Whereas as soon as you have a challenging neuro patient, it is completely different. And so your experience and what you bring to the table is so much more exciting for their patient.
Yes, I think it is really interesting. And yeah, so I obviously see a cohort of trauma patients, and there's a lot of, we literally have a pattern book of splints. So when we have juniors coming on, that they can literally just look at the pattern and cut a pattern to the needs of our trauma patients. And there isn't a book for these types of patients. Okay. And I think what you need to do is incorporate your knowledge of kind of that, neurodiagnosis or rheumatology diagnosis, or all the other weird and wonderful conditions we might see in between things. You want to be pretty confident that they're not going to have a return of activity, because obviously you don't want to go down a compensatory route. Yes. If you're looking at a return of activity, so you're confident that you're taking the right approach from a rehab perspective for them. And yes, I think there's the thing about being confident not to think outside the box and not to have to think within a pattern type mentality. It's looking at the problem, knowing what's going on, and reaching a solution that works best for your patient.
So how are you going to teach us that? Because as you said, are you going to use some patients as examples, or you're going to get us into a different mindset?
Yeah, I think case-based studies is really useful. I've recently done a lecture at University of Winchester, and I think that's where the students engage best, is where I've had a couple of patients who have been willing for me to share their images and their videos with their face not in it, for teaching purposes. And I think thinking about those case studies is really rewarding. It makes it much more tangible. And then a lot of the splints are quite simple to make. And actually, I don't think they're a challenge for experienced hand therapists that are used to splinting. I don't think they're challenging to make. But what is it's that clinical reasoning up unto the point of making the splint. So thinking about actually, how am I going to solve this problem? So I've got a handful of case studies I'm going to bring forward to discuss, and thinking about what the problems are, what's going on, and why we're going to do the things that we do, and talk about those meaningful activities to the patient as well.
Absolutely. I'm actually, you reminded me of a patient I'm treating at the moment. He had a ulnar nerve palsy, and so the surgeon did some tendon transfers for him to regain extension, but he really can't. So he's almost got a little bit of a cupped hand. And I met him at the gym. I swim, and he's swimming at the gym, and he has these they're paddle splints that you buy in a sportsman's warehouse. And I could just see that his hand was not fitting on this pedal because he couldn't straighten the hand. And now you've got the straight pedal, and then you've got this cupped hand. So I said to him, why don't you come see me? Let's see if I can make you your own pedal. And I did that, and we've kind of accommodated the curvature of his hand and the contours, and now we're going to be making him a dynamic radial nerve splint, because actually, although he's got an ulnar nerve palsy, that's what he needs. And he absolutely loves this pedal splint. He just thinks this is the best thing ever because he can do what he loves.
And sometimes I imagine that probably wasn't a challenge for you to make. It probably was quite a simple approach in terms of what you're doing, but what makes a big difference. Similarly, I've got someone who had a very mild spinal cord injury, which just left quite distal problems similarly. So he's got like a mild ulnar nerve kind of clawing issue. And actually what was causing most problems for that patient was that the rest of his strength globally pretty good. Median radial was largely unaffected, but his little finger just obviously was just sat out into a really abducted position. And just that typical thing of us getting in the way, he was getting stuck on his trousers. And the simple thing that we made was just an orthocast body strap splint so that he could slide it on and off. We made him a stash that he could have around the house and everywhere else. It just meant that finger just wasn't in the way. He could do everything that he needed to do. It was so subtle, so aesthetically it didn't look like a big medical device. People wouldn't even notice. It meant he could still move his IP joints. Things were moving quite well, and he could do everything that he needed to do, but it's just the simple bit in between.
Oh, yeah, that's brilliant. Well, I'm excited about your talk because, I think it will just start to reinvigorate a lot of ideas in therapists who are working with patients, because sometimes it can be the last thing we address because there's so many other problems that we're addressing. But really, if we address those issues first, we immediately change their quality of life and their independence.
Absolutely. And if you talk to a patient, they're not going to tell you that they want an improved range of movement. That's not generally in their vocabulary, but they'll talk about their functional goals that are meaningful. And if we can get them on board by, having a couple of quick wins from a functional perspective, that will make a big difference. You're thinking about your patient rapport and your relationship and how much engaged they're going to be and what's meaningful to them. They're going to feel really appreciated that that's been looked at.
Well, I think that we are very honored to have you present at the summit, because not only are you doing your MSc, you're heading a unit, you're a superb clinician, but you're also a lecturer. So this is your forte, and I know that splinting is your passion.
I am. I'm one of those really annoying people that love what I do. I work with a great team in Southampton, and I really enjoy lecturing. So I've done some guest lecturing. I run a kind of a national course alongside a couple of my other very experienced colleagues, surgeons and therapists. And so I really enjoy teaching that and sharing the stuff that I'm passionate about, and trying to get people on board and being enthusiastic about the differences that we can make from a hand therapy perspective. So I'm really excited to share that.
Oh, well, your excitement is bubbling over. So I'm really, really thrilled. Thank you so much, Kate. And it's been so lovely to get to know you. And you are bringing back a lot of memories for me, because my 10 years in the UK were extremely happy ones. And it's also where I specialized as a hand therapist. So, and I did go sailing in Southampton.
Yeah, it's a beautiful bit of the world. It's lovely. It's a really nice place to be. It is. It's really good. The NHS is an amazing, huge incorporation that serves patients really well. So it's nice to be part of it.
Yes, well, we'll see you at the summit very soon. Thank you very, very much.
Fantastic. Thank you.